Welcome, everyone, to our live webcast. Amyloidosis 2030, a SyFy special, a look 12 years into the future at how the risks of AL and ATTR will be managed and the diseases treated. Thank you for joining us. My name is Mike. I'll be the operator for our presentation today. Now, before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings you may have. During this presentation, you'll see the following multiple choice polling questions. They will appear on your screen. To participate in the poll, please select the button to the left of the answer that best represents your views or experiences. On the right-hand side of your screen, you see the text chat window, a large window which holds all of your sent messages, and a smaller text box at the bottom where you can type in your questions. Send a question, click in the text box, and type your text. When you're finished, click the send button. All questions that you submit are only seen by our presentation team today, and your questions will be responded to in the order in which they were received and will be addressed at the end of our presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. If you would take a moment to complete this survey, as it will help Amyloidosis Foundation plan future web events. And at this time, we are joined by our presenter, Dr. Raymond Comenzo. Dr. Comenzo is Professor of Medicine and Pathology at Tufts University School of Medicine and Director of the Blood Bank and Stem Cell Processing Laboratory. He received his medical degree from Boston University School of Medicine. He completed his internship and residency in medicine at Boston City Hospital, followed by his fellowship in hematology oncology at New England Medical Center. Dr. Comenzo is board certified in internal medicine, medical oncology, and hematology. He is a member of the International Myeloma Working Group, the Scientific Advisory Board, International Myeloma Foundation, the Eastern Clinical Oncology Group, ECOG, Myeloma Committee, and a board member with the Amyloidosis Research Consortium. In addition, he holds memberships in the Massachusetts Medical Society, American Society of Hematology, ASH, and the American Association of Blood Banks. Dr. Comenzo is also a reviewer for Transfusion, Journal of Clinical Apheresis, Blood, Journal of Clinical Oncology, New England Journal of Medicine, Leukemia, Cancer Research, and Hematological. His major research interests include autologous stem transplantation and novel therapies for systemic amyloidosis, gene splicing therapy for light chain diseases, and the role of proteasome inhibitors in plasma cell diseases. Dr. Comenzo was a member of the Amyloidosis Foundation Board of Directors for many years. He's currently a member of their Scientific Advisory Board and has been since 2006. With that, as we mentioned, there will be a couple of different polling questions we'd like you to respond to. So first off, if you would take a moment to complete our first polling question, just to get an idea of who is participating on our webinar, if you would choose the response that best fits you, and you see the various responses that are available for you. So at this time, if you could, just go ahead and click on the radio button next to the response that best represents how you feel about our first interactive polling question. We'll give everyone just a moment or two to make those selections. And again, we appreciate your responses to our first interactive polling question today. We will then move forward with our next question. If you have a moment or two and would like to respond, if you are a patient, what type of amyloidosis do you have? And we'll give everyone, again, just a moment or two to make their selection to our second interactive polling question. And again, with that, we do appreciate all of your responses to our polling questions during our presentation today. Speaking of our presentation, it is time to begin with our presentation. So with that, we'll again welcome Dr. Comenzo in to begin today's presentation.
Good afternoon. It is truly a pleasure and a privilege to participate in this webinar at a point in time where the Amyloidosis Foundation is celebrating its 15th year in existence. So much has happened in the past several decades. And what I'm going to talk about over the next 40 minutes is where we could be in 12 years. I'm going to be using disclosures that are relevant and relate to existing companies like Amgen and Unum and Janssen. Those are the companies that I am dealing with currently. I'm dealing with some others, but those are the key ones. And I have invented companies: Baldy Rise Pharmaceuticals, Tarantella Biotech, Devoted Generic Enterprises, Creative Depleters Biosciences, and of course K&L Biotech. These are invented companies with fictitious drugs, but they're drugs that are under some level of development currently, and I think that you'll enjoy this science fiction-like approach to amyloidosis 2030. But let us not overlook the target here. The target here are the fibrils of amyloid that can be deposited by numerous proteins that are abnormal and a protein that's normal, transthyretin. I'm going to be talking basically about transthyretin and light chain amyloid, and I'm going to take a case-oriented approach. In 2030, an 18-year-old man whose grandpa was just diagnosed with hereditary amyloid, grandpa has heart and nervous system disease, goes to see his primary care nurse practitioner, because in 2030, most primary care will be administered by nurse practitioners. The nurse practitioner obtains a genetic screen and an NT6 level. That's a fictitious protein, but in 2030, we'll not only be able to identify the hereditary mutation, but we'll also be able to somehow assess the risk that the patient may develop disease in the near term, because we know that currently in families with hereditary amyloid, as the mutation goes from generation to generation, younger people can experience symptoms. That phenomenon is called anticipation. Well, the NP tells him to come back in a week. He returns, and he's told that he has the gene that his grandpa does, and that the NT6 level in the blood is high. The nurse practitioner prescribes Tranpress. It's an invented drug. The generic name for this invented drug is Quatransterson, and it's made by Baldy Rise Pharmaceuticals. He gets a subcutaneous injection every 3 months. So in 2030, genetic testing for hereditary amyloid will be widely available. Initiation of therapy will be based on a biomarker that correlates with risk of symptomatic disease, whether it's a serum marker, genetic marker. There will be markers that will be used to guide therapy. Treatments will be every 3 months with a small injection under the skin. And indeed, there is a preparation like this in clinical trials today. The chemists have gotten very smart about how to administer these types of drugs. In the future, patients will never get significantly symptomatic, but I've made up a major long-term adverse event, gradual peripheral vision loss, because these patients will need to be followed for unusual events since they'll be treated for so long. Aha, so what happens in 2040 after this young man gets married and wants to have a family but has that gene? Well, his nurse practitioner refers him and his wife to the genetic modification service at a local medical center. He undergoes a series of injections to replace the ATTR mutant gene in 98% of his spermatozoa. 2 months later, his wife has a positive pregnancy test, and plans are made to test the circulating fetal DNA for the normal and, of course, the mutant TTR gene. We are currently testing circulating fetal DNA for genetic abnormalities, so that's not something new. And the revolution associated with modifying genes is here, and there are companies that are using this technology to develop treatments for genetic diseases. The technology CRISPR-Cas9 disrupts an abnormal gene, deletes the abnormal part, and corrects it by inserting a normal piece. So that's not science fiction. That's an area that's being actively explored now because of progress in science. So in 2030, we'll have genetic therapy for hereditary ATTR. Initiation of therapy will be based on some sort of screening. Patients and their children will be followed closely for life. The injections for deleting the gene use a novel approach, as I've described, and I've also mentioned that screening for circulating fetal DNA is routine. So the first lesson in this case is that the risk of systemic amyloidosis will be the basis for treatment. We're unlikely to wait for this young man to be 50 and sick. Progressive organ damage will be a rare event in the developed world for those who come to attention and are diagnosed. ATTR mutant will become the poster child for modern treatment of rare genetic diseases, and those who know they have the mutation will want to have children, and of course medical research will oblige. Second case, 64-year-old man. Carpal tunnel syndrome, has surgery, and ATTR is identified by Congo red and mass spec in the surgical tissue. Again, genetic screening is performed, and he's positive for a polymorphism, which I've made up, called a cell-1 polymorphism, that is associated with wild-type ATTR. A D1 antibody scan is performed, and very early evidence of ATTR cardiac involvement is picked up. He's treated with a fictitious drug called Aramafor, carfaltamate, made by Tarantella Biotech, 100 milligrams once weekly by mouth. Now, this fictitious drug has a particularly fictitious mechanism of action. Aramafor is a bispecific variable conformational depleter that binds to both the monomeric form of transthyretin, and once TTR is captured and the conformation changes, it binds to red blood cells. The TTR monomer is delivered to the spleen. TTR is removed in the spleen. The conformation of Aramafor reverts to its native form. It's released from the red blood cells and is recycled back into the circulation. The half-life is 4 days. So treating wild-type ATTR in 2030, well, we're going to have very effective therapies. We'll have multiple effective therapies, I suspect, in a very short time. In 2019, we hope. Initiation of therapy will be based on early diagnosis of risk of cardiac amyloid by some screening technique. Active research will seek to identify with high certainty those who are at risk, and if patients are treated early enough, a majority of them will never develop AFib or heart failure with preserved ejection fraction on the basis of transthyretin cardiac amyloid. Patients who present with advanced disease, which will still occur to some degree, will be treated with multiple agents, such as the two fictitious agents I have described. So lesson 2 with case 2 is that ATTR in 2030 will be the major form of systemic amyloidosis. Its treatment will cost the healthcare system a bundle, but the cost of a life year per person saved will be estimated at about $75,000, and patients will work while they're treated and pay taxes. So Social Security disability will be needed infrequently for ATTR wild type and hereditary ATTR. And this is a figure from an article we published with colleagues last year showing the different types of agents that are available to treat transthyretin amyloid. There are the suppressors, such as patisiran, which was approved last month, and enatersen, which is likely to be approved very shortly. There are the stabilizers, such as tafamidis, which will likely be approved next year. And then there are the drugs across the bottom, like doxycycline, which disrupts the fibrils. Now, the monomer had no drugs associated with it in this figure, but there will be new drugs that will capture the monomer. One is in clinical trials now, and I suspect that others will be developed as well. Whether they'll be as good as the fictitious Aramafor, who knows? So let's move from ATTR to light chain amyloid. As you all know, the heart and the kidneys are frequently involved in AL amyloid. And this image shows a kidney biopsy. On the left is the Congo red stained section of the glomerulus, and also a small arteriole. On the right is the same image viewed under polarized light, where you see the apple green birefringence that's pathognomonic for for amyloid. Well, in 2030, a 51-year-old woman who spins regularly reports that spinning is becoming more difficult for her. She sees her primary care NP. She gets a little short of breath at the halfway point, which is something different. A highly sensitive troponin T is checked and is elevated, and free lambda light chains are found in the blood and are monoclonal by mass spec. The NP also checks the BCMA protein, which is a marker of clonal plasma cell disease, and looks for certain genetic abnormalities in the blood. The diagnosis of systemic light chain amyloidosis with cardiac involvement is made, and the mass spec abdominal fat aspirate is confirmatory. In 2030, awareness of AL will have increased dramatically because of the fact that treatments are available for transthyretin amyloid. This is already happening. Cardiologists are hearing about amyloid at their conferences. They're going back, they're seeing patients, they're wondering if patients with certain findings have amyloid, and they're calling colleagues. It's an irony that for years we've said that AL is the most common form of amyloid. Well, it's not. And now that there are treatments for ATTR, will involve the cardiologists who will be case hunters because they have agents they can use to treat patients. So there'll be diagnostic blood tests for cardiac involvement and for the plasma cell burden. The BCMA is a real test. Patients will be diagnosed earlier, we hope, and all AL patients will be treated on national clinical trials. That's my fondest hallucination looking into the future. So the patient comes back 2 days later and learns that the clonal plasma cells, because we'll still be doing marrow aspirates and biopsies, were codependent on two BCL pro-survival proteins, MCL1 and BCL-XL, and were driven by an oncogene that's related to BCMA, MYC. The proteolytic pathways were only level 1A, meaning that limited amyloid depletion could be anticipated, because in 12 years, I believe we will have assays to tell us how individual patients handle the deposits. Some patients can remove them a little faster than others. They'll have better proteolytic pathways, and we'll want to know that because it will likely influence our decisions regarding therapy. And in this fictitious case, results meant immediate curative therapy was required. So the patient enrolled on an NCI trial, 2023-18, for transplant-eligible high-risk patients with limited proteolytic endowment. She was treated with a bispecific antibody, BCMA CD3. There are multiple bispecific BCMA CD3 antibodies in clinical trials now, as well as daratumumab, which you know is an approved drug, and low-dose CELMoD-4 for 3 weeks. Now, CELMoD-4 is a fictitious drug, but it's one that inhibits the BCL2 pro-survival proteins, particularly MCL1. In her case, after she was treated, blood stem cells were mobilized, as we currently do with GCSF, but there'll be other proteins used. In this case, the fictitious protein is the anti-alpha V monoclonal. The patient was then randomized to the transplant arm. She received targeted melphalan at 140 milligrams per meter squared because that's the safest, most effective dose. And 3 weeks later, and it's important that with that dose you can begin to treat patients almost immediately after transplant. On day plus 21, 3 weeks after getting her stem cells back, she receives a week of low-dose IV of prostanone, which is a made-up drug, and the BITE. On day plus 60, she begins an oral proteasome inhibitor. As everyone knows, there is one already available, Ninlaro or Ixazomib, and the pill CELMoD-4. 4 months later per protocol, that's 6 months after her treatment and her consolidation, she has measurable residual disease testing. Very important. The MRD testing revealed persistence of the clonal disease despite the fact that she had achieved an amyloid CR. Light chains had normalized, ratio had normalized, immunofixations were negative. Her cardiac function had improved based on the highly sensitive cardiac troponin T. But because she was MRD positive, she had treatment for 6 more months, changed to IV eprostenone and the oral proteasome inhibitor, because eprostenone is a more effective MCL1 inhibitor, more potent than CELMoD4. So that's the way we'll be approaching things, I think, in 12 years. So lesson 3 from this case is that the treatment of AL will become more intensive, in part because patients will be diagnosed earlier. An MRD negative complete response will be the target for therapy. We're aiming for cure. The intensity of therapy will be in the context of the patient's proteolytic endowment and the patient's capacity to limit deposition by mobilizing the deposits. Genetic screening will be a standard of care. MRD testing will be a standard of care. Many more drugs will be available for use, including proteasome inhibitors, IMiDs, or immunomodulatory drugs like lenalidomide and pomalidomide, but there will be newer ones. Monoclonal antibodies, multiple monoclonal antibodies, and BiTEs, the bispecific antibodies. There'll be inhibitors of the BCL2 family pro-survival proteins. But, and this is perhaps an article of faith of mine, MEL-based stem cell transplant will still be used. Melphalan-based stem cell transplant is a great success story, not only for amyloidosis, but also for myeloma, although it's a little more controversial there. I don't believe CAR T cells will rule. I think BiTEs will replace CAR T cells. And I think, unfortunately, the concept of having depleting drugs of monoclonal antibodies that remove amyloid deposits or methods that remove amyloid deposits will still be aspirational for AL in 2030. And to some degree will be less critically needed because patients will be diagnosed earlier. Melphalan is a derivative of mustard gas, a weapon that was used 100 years ago in World War I. We see from these pictures of men in the trenches. Many, many thousands of soldiers were killed by mustard gas and significantly maimed by mustard gas. The morbidity of mustard gas led to its development into melphalan, the chemical structure of which is on the top of the right-hand column. And eventually, melphalan was synthesized and used in clinical trials and found to be active in multiple myeloma. And in the early 1980s, was used by researchers in the UK, Tim McElwain and Ray Powells, to treat patients with myeloma. And refractory patients responded. There was a dose response. However, they didn't have stem cells, so the period of neutropenia was quite long. And we know that melphalan can cause a stem cell injury state as well. But I think melphalan in the form of IV melphalan targeted to patients, customized to patients, will be used 12 years from now still. Bortezomib, the key agent that was first in class in the proteasome inhibitor category. There are now several other proteasome inhibitors approved for clinical use. But bortezomib was based on Nobel Prize-winning research conducted by a number of scientists. Ciechanover, Resco, and Rose won the Nobel Prize in 2004. And what bortezomib does is it prevents the cell from throwing out the garbage. Proteins are labeled by ubiquitin, they're digested by the proteasome, but if you inhibit the proteasome, the time clock within the cells and the protein degradation apparatus within the cells, a significant portion of it, is paralyzed, is changed, and the cells can't deal with that. And in many instances, they die. And in the case of plasma cells, the proteasome endowment in plasma cells is actually low because they're professional secretory cells and handle proteins fairly well. But if that endowment is impaired, they can die. We know if you combine stem cell transplant with melphalan and consolidation with bortezomib, as was done for a number of years at Sloan Kettering, you can see dramatic long-term outcomes for patients who achieve complete responses, whether the complete response is achieved with stem cell transplant or with a combination of stem cell transplant and consolidation. See long-term survivals measured in many years. And then, of course, there's the new member of this triumvirate, daratumumab. Daratumumab is an anti-CD38 monoclonal antibody. It enables the death of clonal plasma cells by multiple mechanisms, the most notable being antibody-dependent cellular cytotoxicity, or ADCC. It's highly effective in AL. And it's currently being studied in the upfront setting for newly diagnosed AL patients in a clinical trial called Andromeda, a very important trial. And I expect that daratumumab will change the natural history of AL as well. And there are other CD38 monoclonals, isatuximab being the most notable one, that are in development, and there are actually CD38 BiTEs in development. I think it's going to be a challenge to bring those forward myself, but CD38 we have not heard the last of CD38 monoclonals, let's put it that way. So, moving on now. It's 2030. This 45-year-old woman sees her primary care NP because she's got soreness and numbness in the right wrist. A free light chain assay is done out of concern for carpal tunnel. Light chains are elevated, ratio is abnormal. Carpal tunnel surgery is performed. There's AL in the tissue. An abdominal fat pad aspirate is positive. Marrow studies show 3% lambda-restricted plasma cells. The gene in those cells is evaluated, and it's an IGLV1-44, a gene that is associated with cardiac amyloid. The woman is asymptomatic. And in 2030, we will be treating the risks of AL in as much an intelligent fashion as we have begun to treat the risks of symptomatic myeloma over the past 10 years. Carpal tunnel patients will be assessed for amyloid. Patients will be diagnosed with smoldering amyloid. Risks associated with smoldering amyloid, that is to say the risks of progression to organ damage, will be characterized in part based on the light chain variable region gene use of the lambda clones. There will be a national trial that will enroll these patients, and randomization will be to monoclonal antibody therapy versus observation. Again, this is a speculation. The national trial will enroll smoldering AL or SAL patients, randomized as described. The primary endpoint will be onset of organ involvement. The monoclonal antibodies, now these are totally made up, luxadolimab and coliximab made by K&L Biotech, will clear the circulating free light chains from the blood. Major side effect over time will be splenomegaly, so there'll be interruptions of therapy or other interventions to reduce enlargement of the spleen. Well, in 2030, what about monoclonal gammopathy of undetermined significance and smoldering multiple myeloma? Well, those syndromes will be very aggressively investigated. We'll try to register as many patients with them as possible because they'll progress to myeloma in some instances, progress to amyloid in other instances, and some of them from MGUS will progress to lymphoma. So one of the things that we could do is study the variable region gene use in patients with smoldering myeloma and also study the light chain glycosylation patterns, helping in both cases to identify risk of AL. Now, studying the light chain glycosylation patterns is something the doctors at the Mayo Clinic are doing for kappa light chains. And it's been a very interesting avenue of investigation. On this clinical trial, patients will be followed every 6 to 12 months, perhaps even more frequently since they'll be receiving the monoclonals. Well, there currently is a trial seeking AL amyloidosis very early. It's called the SAVE trial. Patients from all over the country send us their blood, and we try to identify the light chain genes that are causing smoldering myeloma, or MGUS, of the lambda type. Now, there are certain eligibility criteria with respect to the light chain. So the light chain levels have to be of a certain degree, and the ratio has to be abnormal in a certain way. Of the patients whom we've screened, we've identified a case of amyloid. A patient who went on to be treated and is doing fine, but a patient who had smoldering myeloma but didn't know that the diagnosis was smoldering myeloma with AL amyloid. So the lesson in this case is that precursor states exist. Earlier diagnosis means that smoldering patients will be found. We know already the timelines for progression to AL, based on Brendan Weiss's work at Walter Reed, can be as long as 10 years or more. And the timing of chemotherapy and stem cell transplant will be a matter of debate in these patients. And registries, where cases are registered and followed, will publish data to guide decision-making. Well, a couple of weeks ago, the American Society of Hematology announced that they had gotten $20 million as part of the Biden cancer moonshot to develop a registry for multiple myeloma patients. Can a registry for AL amyloid and of course, for ATTR patients be that far behind? I don't think so. And now, as bright as I've painted the future, we have to realize that there are going to be areas of the country which, still struggle to diagnose patients early. So the 72-year-old rancher in Montana has had worsening shortness of breath for a year. He's seen at the family clinic in Great Falls. He's got hypertrophy, a low ejection fraction. He's got the restrictive pattern that's seen with amyloid involvement of the heart. He's got an IgG kappa monoclonal protein, a PYP scan that turns out to be positive. His daughter flies in from Green Bay and takes him to Mayo Clinic in Minnesota to see the good doctor Tex Corrales, who's an amyloid expert. After tests, Dr. Corrales says you have systemic AL amyloidosis with advanced heart involvement. Amyloid was found in the fat biopsy and was kappa type, caused by the plasma cells in the marrow, the kappa light chains they make. The marrow plasma cells had genetic abnormalities, including a chromosome 1 abnormality. Treatment can stop the production of the light chains, but cannot reverse the damage to the heart. Well, the chromosome 1 abnormality, gain1q, is something we find today in a significant, although not majority, significant percentage of patients with AL. And what it suggests is that these patients may be more sensitive to proteasome inhibitor. And after telling the patient that we can't reverse the damage to the heart with chemotherapy, Dr. Corrales says the Coracyst might help. You're seeing a heart doctor tomorrow. You may have a small device implanted in your body that will help the heart deliver more blood. The device is safe while you're getting the chemotherapy pills. It does require surgery for placement. Transmit your heart rate and blood pressure directly to us. You'll have to come back here at least every 3 months. I'll go over the rest of your test results with you and prescribe the chemotherapy pills after you see the heart doctor. Well, the Coracyst may look something like this: a small device that helps to move the blood in a way that the restrictive cardiomyopathy can tolerate and allow the patient to have better perfusion of the organs. A year later, rancher comes back. He's now 73, and he tells the doctor, "I'm tired of the noise this thing makes," referring to the Coracyst. "I need to repair my fences. My ranch is closed range." Well, he comes back with his grandson and has the testing. And then his grandson brings him to the heart doctor there at Mayo Clinic, who's stunned to see the echo results. The heart doctor agrees to remove the Coracyst with a right subclavicular approach. Some of the wires will be left in, which may mean the man cannot have an MRI in the future. But the device will be removed because he doesn't need it. The echo shows his heart's gotten significantly better with chemotherapy, and the testing shows that he's in an MRD negative CR with pills, with an oral proteasome inhibitor and something like CELMoD4. So with the advances in treating wild-type cardiac amyloid, Cardiac amyloid programs will spring up like wildflowers. It's already happening across the states. Better supportive care will help patients who present with advanced AL cardiac disease as a result of the increased involvement of cardiologists in care of amyloid patients. Left ventricular assist devices as destination devices will be widely used. Large clinical trials for ATTR will be led by cardiologists. Having them involved will change the landscape of amyloid-related diagnostic and supportive efforts. I also hasten to add that dexamethasone will not be used in 12 years. This patient received 2 drugs and did not receive dexamethasone. That's going to be really interesting and a big change for patients. And finally, we have a 33-year-old man who's got significant GI symptoms, admitted to the hospital, managed conservatively, but has amyloid in the small bowel. It's AL lambda type. He goes to a hematologist. All the serologies are negative. He doesn't have a monoclonal protein. He's got localized AL. In 2030, there'll only be a few interested hematologists at traditional amyloid centers interested in localized AL. However, we're coming to more fully appreciate how sick patients can be, but controversy still exists regarding how to test patients and the wisdom of offering therapy, primarily because the endpoints for therapy will not be well defined. Currently, some of us do offer patients treatment if they're sick and if the basis for localized AL can be defined and insurance approves. That's a key. So, final lesson, there are undiscovered aspects of amyloid diseases. Both AL and ATTR can take localized forms, and we'll still be working 12 years from now on how to assess and manage localized amyloid when the patient is sick. Much work needs to be done in this area. However, having drugs that are relatively safe for systemic amyloid will enable us to wise wise choices when it comes to treating patients who have localized amyloid and are sick. So, once again, these are amyloid fibrils seen by electron microscopy. This is the enemy. We're developing many new ways to approach treating amyloidosis, both ATTR and AL. There'll be new ways to treat other forms of amyloid that I haven't discussed, such as LEC2. And I think the future will be very different than the present. But where we sit here on October 15th, 2018, we look back at the last 25 years, and the advances have been remarkable. Patient advocacy groups, such as the Foundation, have helped immensely, not only creating solidarity among patients, but also prodding the pharmaceutical companies to make advances, prodding those companies that have drugs for myeloma to test them in amyloid patients in AL, and moving the ATTR-interested pharmaceutical companies along to complete their clinical trials. Treating patients at risk of progression of amyloid is indeed to some degree becoming a standard of care. We don't want patients to suffer organ damage. Maintaining organ function really remains a principle of therapy for patients with ATTR and AL. And we'll learn a lot more about how to do that over the next 12 years. Patients will benefit, families will benefit, and knowledge, scientific knowledge, clinical knowledge is indeed power. I once again want to thank the Foundation for this opportunity, and I hope you enjoyed this look into the future. I want to acknowledge all of the patients and their families who've allowed me to become part of their care teams, many colleagues all over the world, the funding agencies that have supported our laboratory, the pharmaceutical agencies that have supported investigation, and the local foundation here that has supported my research lab, and current and former recent lab members whose names are listed here. Thank you.
All right, and thank you so much for a tremendous presentation. And with that, we will now move on to our Q&A section of the presentation. And so again, just a quick reminder that to send in a question, you can simply use the text chat located on the right-hand side of your screen to submit a question. Type your question in the small text box at the bottom, and when you're finished, simply click the send button. And with that, I'd like to turn things over to Dr. Comenzo to begin looking at the presentation questions that we've received up until this point. So welcome to the program.
Thank you very much, Mike. And once again, thanks to the foundation, and thanks to the folks who hung in there for this science fiction special. First question is from Clay Sherman. Your thoughts on efficacy of patisiran versus anautersin versus tafamidis? Is one more effective? Well, the simple answer is we don't know, because they haven't been tested against each other. And decisions will be made for individual patients based on efficacy and tolerance. So if someone is on patisiran and has recurrent infusion reactions, the move would be to anautersin. If someone's on anautersin and has low platelets causing bruising and bleeding, perhaps, the switch would be to patisiran. And once tafamidis is approved, hopefully next year, we'll have a third agent. So the decision to use one or the other at this point in time will be based on efficacy and tolerance, that is, side effects. They're all relatively the same in terms of activity and time to improvement in the quality of life and symptomatology. The next question is from John Matheson. This is fantastic. Perhaps I'm jumping the gun, but are there KALE-101 phase 2 clinical trials? Well, hopefully there will be. I realize that the demise of NEOD-001, the Prothena drug, has impacted the company Calum that has KALE-101, but it's my hope that next year we will see a clinical trial with KALE-101. It's important to keep in mind that there are some differences between the two antibodies, and that KALE-101 was developed in a little more, how shall we put it, progressive fashion, because it was used IV as an imaging agent. So it's been studied a little more thoroughly in patients than NEOD-001 was prior to the initiation of the clinical trials. Brenda Heon asks, do we know more about AL with primary GI involvement? Well, there's some varieties there. There are patients who have GI involvement with AL who don't have circulating light chain. Some of them intermittently get sick, like that man I described in the final case. Some of them we just observe, and if they develop problems, particularly with GI bleeding, then we're sort of stuck, and we have to try and figure out what might help. Patients who have AL with the light chains and plasma cells in the bone marrow and primary GI involvement, they can be helped with treatment, clearly. You control the light chains, you turn the factory off, and very effectively over 6 to 12 months, the GI symptoms usually improve. Claire Montour asks, what do you see for non-TTR amyloid? I am ApoA1. That's a very good question. For some of the non-TTR amyloid types, gene therapy may be of use. We don't know, but it may be. I do know that there are active investigations on the part of at least one company, Intellect2 Amyloid. ApoA1 amyloid is complicated, though, because of the fact that ApoA1 plays a role in other aspects of metabolism. It may be the case that a monoclonal antibody that can bind to the abnormal level of ApoA1, or that can help to remove amyloid, such as the current GSK trial, it may be the case that an approach like that may indeed help patients with ApoA1. And I believe that Dr. Pepe's at one point 2 years ago told me there were several APOA1 patients, including one who'd been treated several times with the GSK double drug approach, where CPHPC is used to decrease SAP in the blood, and the anti-SAP antibodies are then used. So there may be ways to clear the amyloid out in APOA1 patients. How effective they may be long-term is obviously unknown. Kathy. Hi, Kathy. How are you? I still have your mug on my shelf. And yes, Dr. Corellis. I love the shout-out to Dr. Corellis, too. Alex Alloy, I have been diagnosed with familial ATTR but have no symptoms. Let's see if I can make this bigger. Alex, there we go. I am 48 years old. Would I be able to have access without symptoms to the suppressor drugs to prevent the symptoms and suppress the gene? Good question. The insurers have not yet taken a position of clarity on the two drugs, patisiran and anodersen. They'll have a third drug, tafamidis, to deal with next year. CMS has allowed us to go ahead and begin treatment. We have a patient on patisiran. The issue is really what you define as symptoms. Let's say an abdominal fat pad is done, and you have amyloid in your abdominal fat. Let's say very, very careful neurologic exam is done, and you are losing sensation, perhaps in the lower parts of your feet. Are those symptoms? Those are signs, what we would call signs of disease. And with the right medical evaluation, you may be able to have access to one of these drugs. I have to think that there will be investigators who will work with companies to determine the timing of intervention. And there will be more sophisticated testing available to help along the way. So I wouldn't give up. This is a very fast-moving area and one that is of great importance to the companies that have produced these drugs. Mr. Jack Fortner says this presentation appears geared for doctors or medical students. Why? When 70% of attendees are patients. I understand about 10% of what he's talking about may bail if this continues. I apologize, Mr. Fortner. The patients that I know are incredibly knowledgeable about their particular disease, and I was sort of gearing it to patients and their families who've been mired in dealing with amyloid-related disease, and I wanted to inspire hope. I apologize that I couldn't get through to you. Deb Bedeker, where can we learn more about the SAVE trial? Also, is there any progress on understanding the origin of this? The SAVE trial is registered in clinicaltrials.gov. If you go into clinicaltrials.gov and enter the search term amyloidosis, and the second term SAVE, you'll find it. And instructions are in clinicaltrials.gov. You can also go on Google and put in SAVE amyloidosis, and it'll come up. Yeah, we don't really understand the origin of the plasma cells that become clonal and make proteins that cause amyloid, make light chains or rarely heavy chains that cause amyloid. But we do know that this part of the immune system is very active, and it's the part of the immune system that numerous blood cancers develop from: lymphomas, acute lymphoblastic leukemia, multiple myeloma, AL amyloidosis, Waldenstrom's disease, that sort of thing. And probably it's because there's so much cell proliferation and so many chances for errors to be introduced, genetic errors to be introduced, many of which just result in the cell containing the genetic error dying. But sometimes a genetic error does confer a benefit to the cell, and should there be a second hit, changing another gene in that cell, you may get a clone, and that clone may evolve into some of the diseases that I mentioned earlier. So we really know more and more now than we have ever known before about the precursor states. And in some instances, for example, in lymphoblastic leukemia, we're learning more about the genetic changes of origin. Barry K asks, if you are currently being treated with patisiran, is it important to take doxycycline as well? And the answer is, we don't know. The role of doxycycline is currently in a number of clinical trials, being investigated in a number of clinical trials. And, there are two schools of thought. There are doctors who use it in all of their patients, and there are doctors who use it in transthyretin patients. So hopefully we'll have a much clearer idea in 5 years as to how necessary doxycycline is. Dr. Strum, hello, Dr. Strum, asks, given the long time to clinical presentation of AL, why are treating clinicians in such a rush to induce hematologic remissions at the cost of severe treatment-associated side effects? Why not have early treatment more focused on enhancing quality of life rather than a quick response for a chronic condition? It's an excellent, excellent question. And I do think that there are at least two parts to that scale. One is the burden of disease, and the other is the burden of therapy. And, the fact that we can now treat the plasma cell disease pretty effectively with the drugs we have, and the fact that the organ responses take a while, up to a year to show a benefit in terms of organ responses. And also because of the fact that we use dexamethasone, which, as Dr. Strum knows, is a very challenging drug for patients. The side effects of treatment, the burden of therapy, can be fairly significant. And hopefully in 12 years we will no longer be using dexamethasone, and you do have to adjust the dose of dexamethasone as you provide therapy to patients. And you have to space out the treatments. That's my belief. Intensive therapy with a 21-day cycle of bortezomib-based therapy may be useful for certain patients, but it's certainly not the best way to approach treating AL for all patients. And the other thing that you need to do is you need to measure the light chains frequently, because as soon as you get a response of the light chains that appears stable over several weeks, you can give patients a break as needed for the fatigue, for the insomnia, for the loss of energy that can be associated with chemotherapy. So you can stop therapy even from after 2 cycles if the patient has achieved a VGPR, very good partial response, or a CR. You can stop therapy because that response in many instances is going to be durable for weeks to months, and then resume therapy once the patient has gotten stronger. So there are a lot of approaches to this balancing process. However, in the treatment of malignancies, it is commonly the case that doctors do treat aggressively initially because of the hope of affecting a response. AL is a somewhat different disease, as many of you know. Robin Paradise Montebello asks, should people who have a parent with AL type be tested for smoldering amyloidosis? And my simple answer is no. If it is AL, the likelihood of a generational effect is extremely low. So testing would be negative many thousands of times before a single patient might be identified with a case of AL. At the same time, it's important to note that patients who develop AL and have brothers, sisters, and children do confer a modestly increased risk of B-cell diseases in that lineage. And the same applies to patients with lymphoma or myeloma. Patients with B-cell malignancies come from families in which the risk of B-cell malignancies is modestly increased. It's not significantly increased, but it's possibly 2 to as high as 4-fold increase based on the data that we have. But it's not a situation in which folks should be screened in any aggressive fashion. It should be part of your family history when you talk to your doctor, and the physician who's looking after you with that knowledge will usually be able to make good decisions about if and when to treat you. John Shalene asks, are there any approved drugs for wild type that at least slow down the beginning of the heart? There are in Europe, in Japan, but not yet in the U.S., and that drug is tafamidis. The patients with tafamidis who responded to the drug did remarkably well in terms of improvement in symptoms at 10 months. And indeed, the cardiac biomarkers even went down somewhat with tafamidis, as they did in the patients with cardiac involvement who received patisiran for hereditary amyloid. So I think we'll have tafamidis in a year or so, and I think that patients with wild type transthyretin amyloid will experience a benefit in many cases. Diego Santos, hello, Dr. Comenzo. Hello, how are you? Hopefully things are well. Daniel Rolfe, why are you pessimistic about drugs to help remove amyloid deposits? In part because I think that it's a challenge to demonstrate a clinical benefit that will lead to approval. Hopefully I'm wrong. The other reason is that as time passes, I think we'll be identifying amyloid patients earlier in the course of their disease. And the key in that instance will not be removing the amyloid that's there, but turning the factory off, stopping the production of the culprit protein in some fashion. And perhaps I'm still a little disappointed in the demise of NEOD-001. But, that's sort of where I see things right now. I think it's going to be a real challenge to bring those drugs forward, although I wish Calum all the best as they do so. Robert Hubble, can you speak to cerebral amyloids? Thank you. Well, cerebral amyloid is a very challenging disease because of the fact that it causes recurrent bleeding in the brain. I don't know that a pharmaceutical company has taken any interest in developing a genetic therapy that may be of benefit to cerebral amyloid. It may be the case that some of the gene-related therapies that have been developed can be modified to help patients with the cerebral amyloid angiopathy. The other form of cerebral amyloid, the form that's associated with amyloid per se, with Alzheimer's, has been particularly challenging for pharmaceutical companies to develop drugs and show a benefit. So I'm not sure that the amyloid hypothesis still reigns in that part of clinical drug development. There are other approaches that have been used leading to the development of other drugs that do different things to help patients with Alzheimer's. Kent Wang, what do you see as the treatment to reduce the size of the heart left ventricular wall, given that we now have stabilizers being approved for ATTR? For transthyretin amyloid, I think the stabilizers and these drugs may indeed make a difference in terms of overall cardiac function and perhaps cardiac wall thickness as well over time. With AL, you do see in about 20% of patients who achieve complete responses some reduction in wall thickness and often an improvement in ejection fraction as well. So we've seen this in AL. How it might apply to wild-type transthyretin is unclear at this point, but there is data to suggest that controlling the culprit protein in the forms of transthyretin amyloidosis will translate into clinical benefit, and one of those benefits may indeed be an improvement in the restrictive cardiomyopathy that's associated with amyloid. What is your opinion? Joan Santafanti asked, what is your opinion about the prospects of CPHPC and anti-SAP antibody treatment? Well, it's a real interesting treatment. As I said earlier, it holds promise for patients who have non-AL, non-ATTR types of amyloid. And I'm certainly hopeful that a benefit develops in the clinical research that's going on with these agents. I think it's very important to do the clinical studies to assess the responses and the side effects and make a determination as to whether or not there's significant benefit. So I'm heartedly optimistic. Hillary Collins, what is the standard in defining and monitoring remission today, and how do you see that changing in the future? Well, currently the standard is free light chain assay, immunofixations, serum and urine immunofixations. We do marrows, and we do marrows annually once a year in patients, even if they're in complete remission. And we have an active measurable residual disease program. We use the just approved clonoSEQ method. There are some problems with it. I must hasten to add, in terms of getting the initial trackable genes in a baseline bone marrow, because very often patients with AL have a low level of plasma cells. And also, there are challenges with it for a variety of different reasons, having to do with things like biclonal gammopathies, patients who, as they improve, experience development of other clonal processes. So there are issues with the molecular approach, but I prefer it to the flow cytometry approach because I think that it often provides a straighter approach. And a significant fraction of the trackable genes indeed relate to the variable region light chain gene that we discussed earlier. So my standard is all of the serologies, marrow, and in those who are on a clinical trial for measurable residual disease, to test for measurable residual disease. Todd Elkins, thank you so much for the work you're doing. Are there any diets that could be implemented to assist with prevention of progressing in AL and ATTR? It's a really good question. The kind of dumb answer is low sodium diets for patients who have cardiac amyloid of either type, and the importance of a balanced diet can't be underestimated. The importance of restricting red meat to perhaps twice a week. These are standard guidances that patients are given, and the fact that we are a heavier nation, that obesity is such a problem, really should be factored in as well. Obesity is less of a problem for patients with amyloid, believe me, because weight loss is a feature of the disease in its systemic forms. However, if you are taking active treatment for AL with dexamethasone, you really do have to be careful about your diet and really minimize the amount of junk food that you eat. ATTR is less clear, other than to say a low sodium diet is reasonable, and weight loss does occur with ATTR as well. Pamela Ramos asks, what does doxycycline do for AL patients? The answer is we don't know. The clinical trial was done at Boston University some years ago. It's not been published in detail, but rumor has it was a negative trial on AL patients. And, at the same time, data from the UK, from their amyloid center in London, suggests that doxycycline may be of benefit to patients with advanced cardiac involvement. So the answer is we don't know. A clinical trial is underway with doxycycline and AL, and hopefully we'll get an answer that will help patients. Diego Santos says, I'm writing from Brazil, Rio de Janeiro. Excellent. I hope that this has been of interest to you, Diego. Murray Walensky, are you so pessimistic regarding fibril clearing therapies because of the failure of NEOD001? I think that's what he means. And in part, yes, Murray, in part, yes. However, as I've said, the GSK approach, CPHPC plus anti-SEP, may indeed be of benefit to patients who have non-AL, non-ATTR amyloids. I have to qualify my pessimism. Diego Santos says, my father had the diagnosis of AL amyloidosis. That's unfortunate, Diego. As I've explained already, there is not any likelihood that there will be a generational effect that you might get AL because your dad had AL. Dr. Strum, private message to, thank you, Dr. Strum. Sherman, what is your experience with patients who have AL amyloid and Waldenstrom, which I have? I've been treated with Rituxan. Yeah, so one of the founders of the amyloidosis support network indeed had AL with Waldenstrom's, and we treated numerous cases with AL of patients who have AL with Waldenstrom's. At diagnosis, it's an indication for stem cell transplant once the patient has responded to initial therapy, and certainly Rituxan is a very appropriate initial therapy. The treatment of AL associated with Waldenstrom's late in the course of disease can be challenging. One of the keys to keep in mind is that the amyloid has to be tight so that you know whether it's heavy, light, or heavy, light amyloid. Because if it's only light amyloid, AL amyloid, then the light chain is the target of therapy. If it's AH, heavy chain amyloid, then you've got to follow the IgM. The IgM is a target of therapy. And if it's combined AH-AL, you do have to try and reduce both in order to have an impact on the organ disease. It can be treated very effectively, and there's some data to suggest that the distribution of tissue amyloid in patients with Waldenstrom's is somewhat different than the classical distributions in patients with AL amyloid due to plasma cells. Mr. Santos says his father has amyloid in his heart. He's 89 years old. Is there any treatment available here in Brazil? Well, there are excellent myeloma and amyloid doctors in Brazil, and I believe that Velcade is available in Brazil. And therefore, if your father were well enough to be treated with some modest dose of Velcade and dexamethasone, just those two drugs, and dex at a low dose, he might benefit. But that's certainly something to speak with your dad's doctor about. Marianne Basile, is there any help to clear as well as arresting wild-type ATTR? We'll know soon because the GSK combo is being tried in patients with wild-type ATTR. But I must hasten to add that the cardiac patients who received patisiran, who had hereditary ATTR, had improvements in the heart a significant fraction of the time. and that the tafamidis patients who had wild-type ATTR who were treated had improvements a significant fraction of the time as well. So I suspect tafamidis will be available within a year for wild-type ATTR cardiac disease, and that there will be a clear-cut benefit for many patients who are treated with it. Brenda Hean asks, are there any studies or new advances in treating the damage that the amyloid has done, specifically GI? And the answer to that is, as far as I know, there are not. Now, might there be a benefit to some nutritional aspect that might enhance recovery in the GI tract? I just don't know. And part of the problem here is that we're not studying the organ system damage associated with amyloid as effectively as could be. And you know, that involves having patients willing to donate tissue to investigators who are interested and have the resources to study the tissue for genetic pathways that may give us a clue as to why the organ might get sick and what can be done to help reverse the response of the organ to the amyloid deposits or to the light chains. We are fortunate to have had an opportunity to do this in kidney amyloid, and the data that we have is currently being evaluated by Dr. Varga and will become public within a year. And hopefully we'll identify some potentially druggable targets as the result of the genetic profiling and the careful pathologic evaluation of the renal biopsy tissue that the patients who are on the now defunct RAIN trial contributed. Jana Beck, what treatment is on the horizon to dissolve existing amyloid deposits? Well, there are three that are on the horizon. KEL-101, which will be in clinical trials, we hope, next year. The GlaxoSmithKline CPHPC anti-SAP approach, which is in clinical trials at only a few centers in the United States. And doxycycline, which is in clinical trials in a number of centers. Those are the only three that are on the horizon at this point in time. Allison Keenan, will anti-inflammatories be used for potential prevention? I don't know the answer. I'm of the school that most amyloid deposits are not inflamed. There's not inflammation in most amyloid deposits. So I'm not sure whether the role of anti-inflammatory agents will be developed for amyloid. At the same time, it's important to note that diflunisal, which is an anti-inflammatory agent, and tafamidis, which is derived from an anti-inflammatory agent, have been used to treat TTR amyloid, but not because they're anti-inflammatory, but rather because they stabilize the transthyretin tetramer. Brian McCaddy, is there any link between AL amyloidosis and JAK2 platelet overproduction? I don't know the answer, Brian. I don't think there is, but certainly there may be. JAK2 is an important gene in hematologic malignancies. It hasn't been identified to have a role in either amyloid or in the organ damage associated with amyloid. Deb Bedeker, in 2030, do you envision a standard test that could detect the amyloid protein very early on, say before any symptoms emerge? The simple answer is yes. I do believe there will be tests for both transthyretin and AL amyloid that will enable us to identify not only patients who are at risk, but will enable us to identify the degree of risk they're at. So I'm very optimistic in that regard. Kent Wang, I have function of muscles in my biceps, and I think amyloids may be collecting in other non-organ muscle areas, like my upper shoulder muscle. Do you expect that the current set of treatments being approved for ATTR amyloid will help these muscle tissues as well? I don't know the answer, Kent, but to the degree that the amyloid deposits in your muscles are being turned over by your body, stopping the production of transthyretin with tafamidis, for example, may indeed enable some improvement in your current problem. I just don't know the answer, but I'm optimistic that, yes, improvement could occur. Carol McGee, hi Carol. Is CAR T therapy something that at some point can be used for AL amyloidosis? And the answer is CAR T cell therapy is very toxic at this point, even though it's less toxic than it was when it was initially developed some years ago. I don't think it will have a role in removing amyloid. I do think it may have a role in treating the plasma cell disease associated with amyloid, or in the rare case of Waldenstrom's, for example, associated with amyloid. It may have a role. But as I said in the presentation, I think the bispecific antibodies are going to supersede CAR T cells. Charles Carlson, what is the action of Revlimid? Well, Revlimid is an immunomodulatory agent. It has multiple mechanisms of action. In the plasma cell, it interacts with certain transcription factors to decrease the proliferative capacity of the plasma cell. In the immune system, it enhances certain aspects of cell-mediated immunity and can, for example, make you more responsive to vaccination. So it has multiple mechanisms of action. Pat Napoda, hi Pat. Sorry, first part of my message was deleted. Good to hear you, Dr. Comenzo. Was asking about any potential risks for our daughters. And the simple answer is no. I don't think there are risks for your daughters. As long as your daughters tell their doctors about their family history, their doctors will be attentive to the risk of B-cell disorders in general, as is the case for primary care doctors who see patients whose parents have had lymphoma or whose brothers or sisters have had myeloma. So I don't think there's any extraordinary undiscovered risk for your daughters. Leonard Strickland, Tegsedi was just approved. That's right, and Notterson was approved Saturday a week ago. However, what concerns me are the side effects. Should I be concerned, or should I wait for a drug that does not have these side effects? I'm in my 10th year with ATTR and a heart transplant. I'm also experiencing neuropathy. AG10 and PRX004 are on the horizon. What is your assessment of the drugs? Len Strickland. Well, it sounds like patisiran may be a drug you should discuss with your physician, because patisiran was specifically approved for the neuropathy associated with hereditary ATTR. And as far as I know, it's not contraindicated in heart transplant patients. AG10 is an unusual agent. I don't have much knowledge about it. I have been queried about it by the company. PRX004, on the other hand, is a drug which I've used in the phase 1 trial. I do think, as I said in the presentation, that agents that attack the monomer will be used and will be developed and therefore used in clinical studies. I do think that's a promising approach. We're hopeful that PRX004 goes through the process of clinical development and then is tested in association with other agents, now that we know what the pattern of response is in the responders to patisiran and Notterson and tafamidis. So this is an evolving area where we expect to hear many interesting and hopefully helpful reports and results over the next decade. Messian asks, if light chains remain the same for a while but begin to elevate and are still within normal range, should treatments be considered? Well, this is an area of active investigation and concern. The complete response in amyloid patients is scored based on the ratio in many cases. At the same time, if the abnormal light chain, the one that we know is causing amyloid, starts to increase and becomes higher by 20 milligrams per liter than non-amyloid forming light chain, that is often a point in time when patients are thought to be at risk for relapsing organ disease and probably should be treated. So it's that difference that would impact a decision to treat. In patients with kidney involvement that's somewhat advanced, both light chain levels can go up. And the only real way to assess the risk is probably to use both the light chains as well as the immunofixation, and also bone marrow aspirate biopsy. And therefore, you really have to define the target a little better, because as kidney disease progresses, the utility of the light chain assay diminishes. Or wait until they are not within normal limits. As long as the light chains are both within normal limits and the ratio is normal, I don't view that as an indication for treatment in and of itself. Barry K., thanks very much, as this is very beneficial. Did you earlier indicate that hereditary TTR symptoms show up at an earlier age as the gene is passed down through generations? I did say it can happen, and in some parts of the world, particularly Portugal and Japan, that does happen. It's called anticipation. And that's one of the reasons it's very important for young persons whose kindred is struck by hereditary amyloid of the TTR type to consider testing and to consider being followed at an amyloid center at intervals, particularly now that we have effective drugs to treat hereditary amyloid. Paul Turnley, any benefit to combining another drug with patisiran to help with cardiac involvement? The simple answer is we don't know. And studies of this sort will definitely be done over the next decade. Perhaps PRX004 will be added in patients with cardiac amyloid of the hereditary type with respect to patisiran. Perhaps PRX004 may be added to tafamidis for patients with wild-type transthyretin amyloid in an attempt to really, really control that monomer, that single molecule that causes the disease. And perhaps there will be new drugs that can affect the same outcome and perhaps provide a benefit. The importance of clinical research, of patients willing to participate in clinical trials, cannot be underestimated. If so, which would, Paul goes on to say, which drug would be preferential for TTR cardiac amyloid? And again, we don't know. The clinical trials need to be done. And Diego Santos, the family's been looking for the right treatment, but until now we couldn't find anything available here in Brazil. We've been thinking to travel to the U.S. with him, maybe to try to find a way to save his life, submitting him some new treatment. Thank you very much for the attention. If you do plan to travel to the States, Dr. Hoffman at the University of Miami may be accessible. I know it's a long flight, but it's well worth checking out the Dr. Hoffman's availability and what treatments he has to offer. Lester Fowler, congestive heart failure with pacemaker of amyloid 2011 on maintenance 1.5 years, lambda kappa climbing, kidney failure. Next treatment will be, well, daratumumab is definitely a medicine that may help relapsing or non-responding patients with AL and organ involvement. It's very safe. F. Myers, I have ATTR familial cardiomyopathy, Alice 65. I am experiencing increasing muscle cramps in my legs. Is there anything, exercise, meds, etc., that can help? You know, that's a really good question. It's probably not a simple, there probably isn't a simple answer, but I do think you should explore obtaining either inotersen or patisiran for your hereditary cardiomyopathy. In terms of the cramping in the legs, it's hard to know what that's due to. I would be impressed if patisiran or inotersen helped, because then you could conclude that perhaps the cramps were due to that mutant TTR monomer. At the same time, if you have heart failure, your fluid status is really important to manage, and sometimes the diuretics that are used can cause some muscle cramping because of loss of things like magnesium and potassium. So I would urge you to review the issue of muscle cramping with your cardiologist. Lester Fowler, why 12 years for AL management? I think you may be alluding to the 2030 title of the presentation. And again, it was arbitrary. But I think given the pace of things, we'll see more and more patients with AL picked up because the cardiologists become case hunters. We have good drugs now, at least 3 good drugs for AL. There will be others coming as the myeloma world continues to turn out really, really interesting, effective anti-plasma cell agents. So I think our optimism is not unfounded. Mr. Myers, who's experiencing the muscle cramps, he's been taking patisiran now for about, looks like a year and a half. Yeah, so I'm not sure. I'm not sure that muscle cramps per se may be related to ATTR, may be related to diuretic use and electrolyte imbalance. If you're on a statin drug, muscle cramps are a side effect of the statin drugs. So these issues really need to be reviewed with your cardiologist. Brenda Heehan, thank you, Dr. Comenzo. I think that's the last question. And the 99 souls who are still on the line, I greatly appreciate your attentiveness, your questions, and I wish you all the best of luck going forward as we continue to make advances in clinical research on all these forms of amyloid. And once again, I thank the Foundation for the opportunity to do this.
Dr. Comenzo, thank you so much for a great presentation and your super responses to the questions we received. On behalf of the Amyloidosis Foundation, we would like to thank all of you for your participation in today's event. Post-event survey will appear requesting your feedback. If you would take a moment to complete this survey, as it will help the Amyloidosis Foundation plan future web events. This will conclude our program for today. Thanks, everyone, and have a great rest of your day.